So my name is Professor Susanne Lindqvist. I work as part of an organization in the United Kingdom called the Centre for the Advancement of Interprofessional Education, CAIPE. And I'm excited actually to say that I'm the incoming chair of CAIPE. It's a national network. And I work closely with IP Global as well. And I am part of a university called the University of East Anglia. And I have the pleasure of chairing or moderating this session today. But enough about me, because the more important people are you, and to welcome our presenters today from Florida, United States, which has lovely weather, I think, because I found out that they have 16 degrees, which Celsius that is, which is great and a perfect temperature. But they are going to tell you a little bit about them, no doubt. But today they are going to present to us a presentation around the disaster day, which is an interprofessional simulated exercise, and a report about that, which is a day event simulation. So I hand over to Joseph and Elizabeth to tell us a little bit more about yourselves. Over to you, please.
Wonderful. Well, we are a tag team, Dr. Buhain and I. I am the Director of Interprofessional Integration at Nova Southeastern University. And for this project, act as the IPE consultant. My university has 22 professions on 9 campuses that are related to healthcare. So we have a big blueprint and a big space. But I want to really highlight our IPE Florida Consortium, so a group of multiple universities that participate and support this event. Dr. Buhain, if you would tell a little bit more about yourself and your background before we start the slides.
Absolutely. Thank you, Dr. Swann. So my name is Joe Buhain, and I have the fortunate role in working with such an awesome subject matter expert when it comes to interprofessional education and interprofessional simulation. So I'm the director here at Merritt College at Fort Myers, Florida, called Florida Gulf Coast University, 26 years old. So it's a very, very new school, and excited to share with you the work that Dr. Swann and myself did.
Wonderful. Well, thank you for everyone for being here. We are going to have a little bit of interaction. As I mentioned, the Florida IP Consortium is made up of multiple schools from around our state in the United States, and looking at disaster day from multiple layers and levels. So we also want to acknowledge psychological safety, truly understanding how we put together our simulation, our massive day, over 1,000 people involved from multiple community partners, as I mentioned, students and facilitators, versus psychological safety in healthcare. As we set up our formal simulation, we follow a NASCL simulation standards and best practices, acknowledging everyone is there to do their best. Also in healthcare, how do we look at psychological safety when we talk about disaster day and disasters that happen around our planet? So as we define this event, it is truly simulated, and we're going to talk a little bit about kind of the how and the why, but it builds a response skill and promotes the interprofessional teamwork, again, from a large group, and looking at how we can prepare to react. My medical background is an athletic trainer, so we have EAPs, emergency action plans, that we practice every single month before we have a sport or an event. So we know when we call our 911 service, who's coming, who's unlocking the gates, where everybody is. But that's for athletic training and sports medicine. For a larger event, we also want to talk about our why. So while we have been doing disaster day drills in simulation for many, many decades, again, around the globe, we had some true devastation in 2024. Hurricane Helene, you're seeing one of the photos. This is right outside Dr. Buhain's campus, a Category 4 hurricane, 140-mile-an-hour winds, record storm surge, catastrophic flooding. Then just 13 days later, Hurricane Milton hit our area. $30 billion worth of damages, and people are still recovering, and it is truly devastating. So we bring in, again, that psychological safety for our students and our faculty that are participating in the drill that still may have living impacts from a recent disaster. Dr. Buhain, do you want to add any personal story from your experience with the hurricanes last year?
That picture that's there is right 2 roads down from my house. So that is that was my house, very close to the university, and the water came right over our backyard. And again, this was my first time here in Florida, moving from Minnesota. So the effect of the water, seeing it rush through, even at a foot of water, it can impact and push a person down. So just sharing with you some of the personal things I've seen. So it was important for me to do this disaster day, to prepare medical providers on how to deal with it, like you said, psychologically, and prepare for it to help other patients in this event if it happens again and when it happens again.
Absolutely. Thank you again for sharing. And we know that we had to support so many students and faculty. And now that we look at how we've put this together. So I'd like to take a minute. I see some action in the chat box. What disaster is in your part of the world? Or do you have earthquakes? Do you have storm surges? Do you have hurricanes? We'd like to just see a little bit of that in the chat box. As you're putting that in the chat box and we're connecting with our audiences here, I want to really address this event mission statements. And kudos again to Dr. Buhain, who put a group of leaders together. And we had almost a task force of discussions and putting ideas in there. And from multiple leaders, we saw the word preparedness over and over and over, collaboration, teamwork. So with Dr. Buhain and his leadership crafting these mission statements, really, of how we're moving forward this event. I want to read that center sentence about uniting diverse healthcare disciplines to build awareness, strengthen communication skills, and enhance readiness to respond to these emergencies effectively and preparing. Yes, we're measuring. You see that last statement, measuring the ICAS tool. Many of you are familiar with that. It is publicly available, and we'll share some of our data out. So in this photo, we want to, again, challenge you to find 13 faces within the photo and really look at how different perspectives can see different things. I'm looking in that chat box, seeing strong winds, tornadoes, hurricanes, ice storms, avalanches, lots of different things that we think about and move forward on how can you prepare, not just your home, but maybe your students and your healthcare environments. So pointing out those different faces and looking at the different perspectives we bring. Kind of in interprofessional education and collaboration, using these definitions, but also really thinking about the concept, why are we in these cylinders of excellence? Why can we not be in that teamwork framework and pushing and pulling our expertise into kind of a united front of how we interact together? So while in our simulation and our schedule, we address and reteach and remind and refresh all of our participants these definitions, we truly look at this continuum overall. And you might have seen this in the literature. For the United States, we have the IPEC, the Interprofessional Education Collaborative, and they've built these competencies. But from the learning continuum in your foundational education, you're hitting some definitions and some experiences from graduate education to today, continuing the professional development. We see this interprofessional education cone expand. But it really brings down to these learning outcomes. And I love this infographic talking about the collaborative behavior, is how do we do teamwork? And often when we do teamwork activities, I ask students to think about, what was the last team you were on? Maybe from a secondary school or a high school or undergraduate education of, I was on the debate club, or I was in the band, or I was on a sports team. How do we translate those behaviors, that collaborative practice, into healthcare? While we all have different accreditations and alignment, we take the simulation. We also take our different healthcare professions. And in the stories we're going to share on how we build this, there is some alignment with the different standards. There is also some collaboration and role clarity. Kind of who is doing what, from our EMS students, which is emergency medical services, to public health, social work, nursing, different therapies that we involve in our day of role and responsibilities. We also, again, with a lot of love, embed competency-based learning outcomes. So specific skills in triage, transport, different ethical decision-making through these disaster scenarios. Please email us if you want the full list of all of our disaster day goals, because under each one of these goals, we have some sub-goals, but looking at really enhancing the collaboration during a disaster response. Number 4, jumping down, as I've already mentioned, the roles and responsibilities in a disaster context. And really, number 5 is evaluating your personal and team performance for continuous improvement. And we collect data from our facilitators and our community partners. And speaking from last year to this year, our next disaster day is in, I think, 7 short days, next Friday. But the objectives underneath those goals are also important. So again, you're looking at a busy slide here, but we've got the phases on the left and the letters and designations that you see, for example, under planning CC2 in red. That is our IPEC core competencies that we use in the United States. I know Canada and the Europe contingency, and many of you have different letters or categories that you're using for these IPEC core competencies, but we all have the same language when we want to organize and communicate information for patients, family, and healthcare team members. Looking at avoiding the specific terminology for discipline, but thinking about overall, how are we moving through our disaster and our simulation? So here's our target audience. Looking at this list, you can see a large group that are involved at Florida Gulf Coast University. And each of these programs have faculty that have served on committees, that have supported some of the conversations that we've had, or have asked to be more involved. Again, love the work that Dr. Buhain and his group have done from our theater programs. And the theater programs serving as standardized patients or actors, and using their skills and their opportunities, again, to participate and be involved. So from our list, our target audience, now we're going to show you some numbers, some metrics from 2004. Again, looking at the balance of what professions we have and how they're involved. But such a great opportunity for these students to work together, as well as our faculty and support. Quick theory burst on Miller's pyramid. When we look at, again, we've modified this from our students' perspective in this bottom area of knowing the knowledge. So again, we're going to use triage, for example. When you see a patient and you're immediately identifying, are they an emergent patient that we need multiple professions, or are they a patient that can sit in triage in a different area? Measuring that, again, very easy, and maybe a multiple choice question or an examination. As we move up the Miller's pyramid, the knows how, the shows how, and the does, you can see the assessment focus or the methods of assessment. But don't we all want to get to the top? We all want to look at how are we ready to cope with challenges in practice, with teamwork and communication. So moving from that Miller's pyramid to the Bloom's domain of learning, and we see the cognitive, psychomotor, and affective, also mirroring that with our United States IPEC core competencies, as you see our values and ethics at the top, roles and responsibilities, communication, teams, and teamwork. So while our event hits all four, we're going to focus again on some of these other behaviors that we can't really talk about in a text. Well, we can talk about it in a textbook, but you got to practice it in a simulation. So here is some of our data when we look at the competency piece of it. In the communication and achievement area, we've got 90%, and this is a combination of our evaluator observations and our post-exercise surveys. So looking at the data, we're hitting a high achievement score from our students, looking at what they're able to gain from just a one-day event. Now in 2024, it was an all-day event. In 2025, next Friday, it's a half-day event, looking at how we're being more effective with our resources and our environment. Again, another busy slide from our evaluator objectives for the students. But we highlighted number 4 for the specific reason and sharing with you all, again, from around the world and looking at your own disasters and emergency preparedness, is we've designed it so the faculty with a specific profession can evaluate clinical and technical competence that might be specific for them. So nursing, for example, they are measuring something specific for nursing, while looking at physical therapy or occupational therapy. In any type of disaster, how are they using their skills to support the patient, the family, looking at different opportunities? So I've shared a lot of the framework, and now we're going to get to the fun stuff with Dr. Buhain and his experience, his military background, and how he's really led us through hitting all of these areas. So Dr. Buhain, the slide is yours.
Thanks, Dr. Swann. So the idea, so this is what you call a CONOP. It's a very busy picture, but we use this CONOP information to overview the whole entire analysis of the simulation. So in the military, we use this as a one-pager. So a lot of times we pass it on to the next person, so it's reproducible. So this is for you, everyone. It's a reproducible map of what you can do for your disaster day. It talks about the mission statement, student learning objectives. It has an end state of what we're really trying to capture, as well as Dr. Swann said regarding the clinical competencies. And then, of course, we had things at the bottom. I think I want to really focus on the bottom, and that's in project management, we call that the timeline. The timeline looks to see where we are crawling first, then we walk, and then we run. The run state is where we're at right now. So we're at the end of the finish line for Dr. Swann and myself for next week. And from there, you can see that arrow there. We tend to just move to that position. And then we have a after action report sometime in December or January. So this is called a mission op statement.
Next slide. Learned so much from Dr. Buhain and his experience in just this crawl, walk, run, thinking about how we've all done it in education for years in our own way. You teach one, do one, see one, and looking at this model. But as he's laid this out, he's really been such a strong leader in bringing multiple and diverse professions into our leadership team.
So the focus from this point on that we're going to really look on is really, where do we design? What do we look at? The nature of modern healthcare really demands a workforce that has capabilities in all sense. So in designing a disaster, you want to look at pre-hospital needs and intra-hospital needs. So the degrees that that Dr. Swann was presenting were all hospital-based professions. And when we look at disasters, most of the disasters occur outside in the field, outside in venues, and often you still have disasters in the hospital, but we had to have a place where there was a lot of people. So in designing this, we started looking at this map. This is this Marib College in Edwards Hall. So we wanted to look and see, hey, can we fit, 200 patients in this location? Can we land a helicopter? Can we get a fire truck? And this was our first location place, and they wanted it here, but the reality is it was going to be a difficult location to choose. So we opted not to do this. It was brought up in the in one of our first meetings as we designed. We were crawling, saying, where is a good location? So we then looked at another location, and this was in the recreational field. And then on the right, we looked at the police department. That's where the helipad's at. In talking with the School of Theater, and talking with Dr. Swann, and talking with the Health and Human Service, we felt that one of the best places would be to adapt it in the recreational field, and the helicopter and the police department and all the fires and EMS can be at that location. If something truly occurred, there was an input and output area where ambulance can actually leave and take off. So the entrance and exit strategy was good. The location was good. The landmark was good. And in Florida, it rains a lot during the summer, but during the fall, which is this season right now, it doesn't rain. It gets hot and it gets cold. So the chances of getting it, if raining, would be very much less. So we looked at the recreational field as one of those locations to possibly do. So it's very important that when you're designing, you're implementing strategies of safety. We want psychological safety and medical safety. So if you're using a big disaster event, the location is an important aspect, not only for the participants, but also the actors. And if an incident was to occur, is there an exit strategy where they can leave and actually take care of that patient? In conjunction, if you're doing a large disaster day event, you want to be cautious of the students or the faculty or the team that's outside the event. So the awareness and communication out to the general public of a disaster event occurring is also important, because you don't want 911, we call it 911 here, to get inundated with false reports. So we also looked at this location. It's called the Kleist Center. This was a great location, but the parking was going to be difficult for our actors. So location 3 was one of the things we also looked at, and we opted not to do it.
So when we go back, oh, go ahead, Dr. Buhain.
No, so we opted to do location 2, which was the recreational field.
Yes. So location 2 is it, after we again did our kind of like a SWOT analysis, looking at the strengths and weaknesses of each as he identified. And then we want to really kind of review with you all the steps for evaluating operationalizing. So we had to determine the committee involvement. So again, a larger committee meeting on a regular basis, looking at the approval of different groups, and we'll identify some of that as well. But also vendor allocation. And Laerdal is one of the companies that Dr. Buhain works with. But that was also when you design a large event like this, of getting the buy-in, and the buy-in from these community partners wanting to participate and loving this event, because not only do they get to show off their equipment, but even the sales representatives jump in and be a part of the day because they want the experience. And I have to share a quick story. At a national convention, one of the reps from the companies flagged me down and wanted to talk more about the experience she had with Dr. Buhain and Disaster Day. And so that is really the impact that this event has with bringing the community partners in and the conversations that happen, the memories and the experiences that not just the students, but the actors, as you mentioned, and the facilitators. Under step 7, we've got Dr. Buhain as our IP director, but volunteer management, facilitator management, simulation development, operations and planning, and community management. So a lot of support and buy-in. Thankfully, we've been able to standardize some of that through our learning management system and a Canvas. That's what we use to have everyone literally and figuratively on the same page, getting the same materials, getting the same documents to be ready. And we wanted to show you this picture. This is the back of the room. Again, our military personnel that come and support this event and actually use it for their own training and evaluation of a practice for them as well. So as we talk about this multidisciplinary steering committee, again, all of the individuals and the buy-in that we need for this event to take place. What we've also found over the last couple of months is other professions that want to be involved, but maybe not know how to be involved. So that has really opened the door for Dr. Buhain and I to have conversations with other professions that maybe not know how they connect to a disaster and how do they connect it back to a student and their content. And really, when we talk about teamwork and communication, it could happen even with a thunderstorm and lightning and the power goes out and you need to evacuate a facility. Well, that might not be life-threatening to the large group. It could be to individuals that need a respirator, that need this electricity for the life-sustaining equipment. So assigning the subcommittees, again, has been fun and an opportunity to build relationships both in and out of the university. But again, the clear communication channels, which looking at how that's taking place in one spot and what is happening behind the scenes. So that bottom picture. Oh, go ahead.
I just want to add on that communication. Clear line communication is good, but what I learned was over communication is bad. So what I mean by that is too many emails repetitively, although you mean well, can be a deterrent. So try and define one email a month or every 2 weeks, and then go from there. Multiple emails to the same individuals, it can be bothersome, so people tend to spam it or delete it. So just be careful with that.
No, definitely. Thank you for mentioning that. And our monthly meeting is a large group meeting. And as Dr. Buhain runs through that agenda, I love watching the chat box because people in the chat box are communicating back and forth. We actually have therapy dogs that come and are a part of this event. We've added in individuals with disabilities, sign language, other opportunities to build. And that's all happening in the chat box as we're making relationships and working with each other virtually until we all show up for the event. Again, you're seeing that large group of students. They might not look excited in that photo, but they definitely are when they get on the field. It is about that commitment and sometimes the schedule conflict. So how we're working ahead of time and aligning those academic calendars. Dr. Buhain has the date really the Friday before Thanksgiving. Everybody, American Thanksgiving, everybody makes that commitment and is ready to roll. So Dr. Buhain, I'd love you to comment a little bit about how you work with agencies within your university and your city.
So the biggest buy-in is, with every province, every agency, every location, there's an emergency management center or emergency management team. identifying that emergency management team is critical because they have a chain, an incident commander, a EMS, a medical provider, a special needs group or ad hoc team. A lot of that work's done, provided that you find those resources in your location. So I have in my institution, FGCU, an emergency management center that connects with the local communities, which made it very, very easy. They connected with the fire, the police, and FEMA, for the Federal Emergency Management for Disasters, and allowed me to have a great relationship with them. And in conjunction, they're required to do yearly, if not every 5 years, a big event, but every year a renewal of activity or renewal of training. So in doing that, we provided a memorandum of agreement, an MOA, or a letter of acknowledgement that we're working with them to not only enhance our interprofessional education in Merritt College, but also their academic and clinical needs for emergency management.
And again, I want to highlight the written documentation. It cannot be overlooked. And even that is a learning point for both students and facilitators and faculty that may not have a background in risk management. They may not understand what it takes to put together some of these memorandums of understanding and what that communication chain of event is. But it's such a great opportunity for people to learn with, from, and about each other. We go back to our IPE definition as we build out this event. And it really cannot be done. I need to acknowledge Dr. Buhain's dean, an amazing individual that has championed this event. And the proposal and the documentation that he expects, as well as how it's impacting the students. What is the outcome? How are the accreditation standards supporting this event? Because it is a financial commitment, but it's also a human resource commitment. Lots of time and energy for everyone at the Merritt College to really kind of support what this is about. And not very many universities do this large, massive event. Even at my university, we model Dr. Buhain and looking forward to hosting our own. But as the IPE Florida Consortium, we have people coming from Tampa, which is almost 4 hours away, down to this event. We have others driving across the state that have medical residents, physicians that are coming and being a part of and supervising some of the stations because of the impact and what we're able to do. So I want to, again, acknowledge the dean that helps support the event. As we talked about those locations, we also want to just think about backup location, as we mentioned, with weather or space conflicts. We even joked, if there is a little bit of a rain shower, those high fidelity mannequins, we'll show you a picture in a minute, they cannot get wet. So do we put them in a parking garage? How do we walk through a backup plan of a disaster event or a simulation? This next Monday, Dr. Buhain is leading a walkthrough for logistics, going through the staging areas, the triage zones, the signage, and even where the volunteers are checking in, the emergency exits, the command center. We have a distributor that's coming in and bringing free water and food for 1,000 people. And how are we really moving through that? And just planning the day is a benefit of how you're going to react in a disaster.
Yeah,
so
that's
here's
so
an example of
cool.
one of our mannequins.
Oh, go ahead.
I'm just gonna, again, the picture again of one of those mannequins and the cardiorespiratory pulmonation, the rescue CPR that we do is part of our training of the day. And again, measuring the student's ability to not just triage, but do the CPR on the mannequin that you see. So the students get the instruction reminder because they've already been trained in CPR, but now they're actually doing CPR on the field with people watching, with noise and crowds, where it would be a real life scenario for the student to really engage and interact from that conversation. Dr. Buhain, you want to add about the vendors?
There's about 10 vendors that will be having. So last year we had 10 vendors. We had 5 on the field: Laerdal, CAE, Gamard, TAC Medical, and Elevate. So the 5 vendors had each brought in a high fidelity mannequin, about $150,000 to $200,000 each. These are higher fidelity. The vendors were very prominent, and what I wanted to do was make sure that we had the actors. So we had about 200 actors, or SPs, simulated participants. And then we also had 10 cardiac arrests with the high fidelity mannequins. So they actually had to do CPR because it was taught in the lecture. So the vendors provided the treatment or the allocation of treatment for those patients. We had low fidelity mannequins like this one that you see, a geriatric. And then of course we had some semi fidelity mannequins where it was wearables. So a lot of variety in reference to utilizing it. And we want to just make sure that it was prominent. So yes, get a hold of your vendors. They will come. And honestly, the easiest access for them to come is because it's free publicity for them. You have the public health, you have emergency management, you have schools, you have other universities, you have colleges that want to come and visit. In the future, if you decide to do something like this, you can charge them because it's an income base for them. Or you could do what I do and ask them to bring their simulator and say, hey, here's free publicity for you, and visit all the people that might be interested in purchasing or looking at your product. So it's a buy-in.
And the buy-in, yes. And the feedback the vendors give in the after action report of, wow, the equipment was used appropriately, or what do we need to do better next year? So again, I love their feedback as they're part of the day. So we have a couple of more slides here, and then we want to open for questions and discussion. But we wanted to make sure that we looked at, again, the team leadership. And Dr. Buhain overall is the chain of command top, and how are we going through each of these sections and these areas. Again, I so appreciate the structure and the organization of the checkpoints, the 90-day, the 60-day, the 30 days prior to the event, and now we're 7 days. And even though there are items like stuffing bags for the students and the information, but also how are we following up with and making sure everybody's ready to go the day of. So really, again, we could do a whole different session on how we develop the simulations, but really looking at the different areas that we were talking about with the mass casualty, as you see there in front of you, but also could we do a chemical exposure, a pediatric trauma, a behavioral health crisis, looking at other opportunities like how do you incorporate high fidelity or VR? How do we look at other objectives that you might want to put in and add? The pilot test of the scenarios at least 2 weeks before the event, so you have kind of all the structure and everything down and ready to go. This picture, again, I love because you're seeing the different armbands for the different students and logistics. You're also seeing really a note on the patient to identify kind of what is going on with this patient, with this standardized patient or mannequin of what this is supposed to do. The volunteer management, again, is another piece of how are we recruiting, how are we providing training. The sign-up system, we do use some electronic sign-ups, and have backup lists. That's the other opportunity you have, is making sure that you have backups, as sometimes things happen and we want to make sure we have everybody together and ready to roll. In that facilitator management, we also wanted to share with you the Pearls. It's a healthcare debriefing tool that we use to break down some of that IPE assessment as part of our IPE day. Because again, those facilitators are taking notes, they're providing support, and looking at how do we cross-train some of those facilitators to make sure that we do have everything ready to go. So as we kind of set that scene and look at the conversations as part of the debrief, the formal debrief for our participants and our students. Love this picture, had to do the yellow arrow. That will be Dr. Buhain and I next Friday in the yellow vests. So you know who is the faculty, who is the facilitator that's been trained.
Right.
We've got our clipboards and our checklists. Dr. Buhain, I see you putting some items in the chat box for everyone, and I love that. Sharing is caring, and we firmly believe that as part of our Florida IPE consortium. But when you have this master operations plan, your MOP, how are we having that command center setup? Radios, backup plans, because there may be a disruption with cell phone service. Looking at student flow maps, equipment checklists, doing a tabletop drill and a walkthrough. Again, for our students and how we're doing our simulations.
So this was, last year we had 2 simulations, one in the Cohen building and one in the field. This was basically the Cohen building, a big room, and you could see how many patients there are and how many students are crowded in that area. So in a MassCal, this organization is one of those things we wanted to do to see how students react and how they can react together. So.
And realistic. As we know, space may not be an option when you're reacting to a disaster and a mass casualty. The community management piece, again, we wanted to make sure that we hit this and wanted to ask you all in your areas, what is your community management? Do you have an emergency medical service? Do you have a national disaster agency or a humanitarian organization? We have in the United States both Red Cross and Salvation Army that will be participating in our event. Again, we've invited these agencies to co-train with us, looking at how we're having them build in as part of the day, but also what they're gaining. So opening the floor in the chat box of who does disaster days and what community management opportunities do you have? Kelly, I see Stony Brook does a disaster event every year, so you know what this looks like, and looking forward to some of our other opportunities for discussion. Dr. Buhain, do you want to address some of these areas that you've put together?
Yeah, absolutely. So this year we have 1,000 patients, or 1,000 people coming. Last year was 600. This year we have about 300 patients. Last year we had about 150 to 200 patients. And then we have the 10 vendors. So we are doubling our amount. Last year we had 2 doctors out in the field for 200 patients. This year we have 7. So what I wanted to do was give the medical doctors a script, a role. How do we identify medical doctors that want to take part in an event, and how do we get them engaged? Because they can't manage 300 patients all within 45 minutes of a simulation activity. So the idea was the team leader of each of the groups is going to go to the doctor. So it's a one-on-one. We'll go to the doctor, and the doctor and the team leader will have a discussion. So step 1 is they're targeting and triaging. The team leader is going to give an S-bar of all the patients that he has on a very generic form. The doctor is going to come back and say, I have 1 spot left in the helicopter, 2 spots left in the ambulance, and 3 in the tent. They have 30 patients. Who are you going to choose based on those life-saving interventions? And how do we create a awareness with ethical boundaries or ethical issues? And who do we decide is going to move forward? So students are going to treat with immediate intervention to sustain the patient's activity or livelihood of activity to survive. And the doctor's going to integrate their knowledge with the team leader's role to help that life-saving intervention. And finally, they're going to work with public health administration to move forward these patients through the next level of continuity of care. So steps 4 and 5 really is the movement or integration of where do we go now? We move these 4 patients. What do we do with the other 20 that are, or 22 or 23 that are left here? How do we move them? How do we address their movement of care in the next level? So I'm looking at it from a getting the doctors involved, getting them engaged, and challenging the students or the healthcare professionals in working with the concept of mass casualty disaster, but also in their profession.
Yeah, thank you for walking us through that. It is a coordinated, beautiful flow. Even simple checkpoints, as you see, from triage to treatment, treatment to transport, transport to command center. So while there's a lot going on, it really is this simple and where people are going. But for the students to make those decisions real time is the benefit of putting together a large disaster day, as we're talking about. Here's another angle of just the mass of students when we put them all in the one room and start the conversation of what's happening during the day and the brief. Here's again another picture we wanted to show you of our simulated participants that has got some moulage, some real fake blood on there, and looking at how we're making sure the students have their own equipment. They have the gowns and gloves, and then you see a military personnel here that's working with them. So again, the students have the interaction and the communication piece. Here's another photo. Again, we're outside. You can see the field and some of the interactions behind this team. But also, when we talk about rapid teaming, some of these students don't really know each other because they're from different professions and they're randomly assigned to the different zones. Again, I will meet my team in my zone for next Friday morning, and how we interact and move through the day is really an exciting piece. So I know we're getting close to time, but we wanted to just share lessons learned. We've talked a little bit about the size of our events, the improvement of the paperwork, the bringing more physicians in to schedule out our day. Dr. Buhain, is there something you wanted to add about lessons learned?
Yeah, just be patient. Everything in regards to what you do on a mass event. I echo the concepts of simulation, debrief, and after action report. There's gonna be knickknacks that you can't control. And that's what a disaster is you have to learn to go with the punches and adapt to it. So one of the key things away is always do a debrief, always do an after action report, provide many minds give you feedback, take it with heart and just go with that and move it to the next level.
And the formal schedule debrief, I think, is important. And Dr. Buhain's already scheduled that out after our day so that the expectation is there. So anyone involved in the event, they're filling out an evaluation form, but then they have a chance the following week to truly share openly what some of their thoughts were and successes. So putting this back up again, our con-op of what this looks like and how it is all going to be pulled together for next Friday. And
so this is next Friday. This is 2025. So you saw some changes at the bottom where it says crawl, walk, and run. I put more emphasis while we did the debrief and we did the after action report. So I put more emphasis on changes they wanted here. And one of the biggest ones that Dr. Swann and myself are doing is instead of doing a full day, which lasted till about 6 p.m. last year, we're doing a half day, which is going to last about 2:30 in the afternoon. So this is a very, very different than what you saw in the beginning, but it gives a good con-op of what's going to be presented next week. And you already see 2025 there.
Yes, we're excited and thrilled.
Oh.
I want to open the floor for questions as we wrap up here. Just a few minutes left. I know your times are busy and we're so grateful.
Excellent. Yeah, no, thank you so much. That's super. Such an interesting presentation and fantastic, huge work. Like, I can only imagine what it's like. So maybe, I mean, you can scan to join and learn more about what they do, which is great. We will have the presentation and the recording available both on LinkedIn, but also on the IPG Interprofessional Global channel or website, where you can look at it or you can share it with others who, for one reason or another, did not have the opportunity. But please, if you have a question, we don't have many minutes left, but we have some time, so we have space for a couple of questions perhaps here, and we can also put it. We have Kwame from Edinburgh asking if there was a cost analysis done for this.
There was a budget analysis that was done for it. The budget analysis we did a analysis in regards to how much it would cost us relatively for moulage, durable medical equipment, things that are going to come, things are going to go. We found out that vendors were willing to supply the measurement of it, so it didn't cost us a lot there. What cost us the most was we supplied lunch and breakfast. Ironically, it was the food that was the most expensive out of the whole event. It was not even the equipment because people were donating it. So, and again, this year, it is the food that it becomes the most expensive. And I could tell you it was really expensive for lunch.
Maybe they have to bring their own lunch, but food and drink is important. You know, it is for building community and working together. I can see that. But yeah, no, absolutely. Any other questions from the floor?
So I was just curious, this is Kelly. I was just curious, when you do the debrief with the students, the faculty, the actors, do they have an opportunity to do that in smaller groups, or do they do it in like a big group auditorium? Because I'm just curious about how that gets done so that students have a chance to really debrief that experience.
That's a great question. So in this situation, no, that's an after action report last year. Last year we did it as they were based in teams. So there are about 20 participants, 20 patients or 30 patients. That was the team. And in there we had educators, 10 educators that were, and then we had one simulation leader. So we had that large group debrief. This year, for every 2 patients and 2 healthcare professionals, we have 1 instructor. They'll debrief those 4. So it'll be a 1 to 4 now.
Yeah,
so
that's excellent.
That's what we're going to do this time. The after action report last year was we needed that. We needed this integration to occur.
Thank you so much. There was a question from Teresa, was it as well?
Yes, thank you. Just quickly, so the ICAS data that you had for the team competencies, is that after this specific activity, is that kind of housed, are those data housed kind of at the uniprofessional level where a linkage to the learning experience might have been at a program, or does this feed up to more of a college or university level for the class to track kind of team competencies over time? And if so, what do you use as database? Using Qualtrics or other platforms? Can you talk just a second about that?
Very good question, Teresa. So Dr. Swann can talk about this. The whole intervention for simulation, I'm very prominent. I've done simulation so long. I believe IPE, interprofessional education, should be the top, IPE. And then simulation is a foundation, because you could do different types of IPEs, like simulation, virtual reality, immersive, whatever it might be. I also believe there should be a pre and post. So I love the ICAS. So to answer your first question, the university here has invested a lot of money in the development of interprofessional education, because every program, as most of you are aware, are siloed into their own integration. Their accreditation keeps them isolated because they're doing their own role playing or foundation on there. I want to break those barriers by doing this disaster day. So ICAS provided me the opportunity to see how students viewed this. So I was with Dr. Swann last month in Nexus, where I presented the perceptions of what student believed interprofessional would be in faculty. So this is how what I did right now for this year is Qualtrics. I did an IRB to measure the values of the students through ICAS with Qualtrics. But the participants or the actors, they are doing ICAS separately because they're outside of the Health and Human Service. They're going to do ICAS independently. So I'm going to do a cross analysis of what the participants feel it would be and the IRB, and value that comparative analysis there. And that's all done through Qualtrics.
Thank you so much.
Thank you so much. And I believe that makes it my time, 4 p.m. In London time, and another time wherever you are in the world. Thank you ever so much for a really exciting presentation and fantastic work. And good luck in the 7 days you have now to make the final plans. It's quite something, isn't it? And maybe, Kelly, in the future, you would like to talk about your, you said you had also a disaster day. Feel free, and anyone on the call, doesn't matter what stage you're at, what you would like to do, please put an abstract together, send it to IPG, and meet us here for a cafe and a chat. We don't have cake here. It's cheap food and drink. We have to sort it out ourselves. So, but I just want to say thank you to Elizabeth Swann and Joseph Buhain from Florida, United States. Hope to see you again. Stay safe, away from disasters, and good luck in 7 days. See you soon.
Thank you. Bye, everyone.
Bye,
Have a blessed
everyone.
afternoon.
Yeah.